Welcome everyone to our MCF presentation. Today we'll be talking about multiple sclerosis, which is done by the group Anodsots Production. Our overview this morning is discussing what is MS, the 4 stages of MS and its prevalence, how MS affects the foot, the assessment of MS, the management of MS, a brief review of the literature with regards to management, and finally viewing our case study video. Multiple sclerosis is described as an autoimmune inflammatory disease which affects the brain and the spinal cord. It occurs as a result of lesions in the myelin sheath which protects the axons and is responsible for transmitting electrical impulses within the central nervous system. Pathophysiology. Multiple sclerosis occurs when the body starts attacking itself, especially the myelin sheath. The myelin sheath is responsible for the protection and insulation of axons, which is important for transmitting fast electrical impulses from the brain to the whole body in an effective manner. Demyelination is characterized as a process of myelin sheath breakdown due to the attack of MS. This induces inflammation and a buildup of sclerotic plaques. Hence, the nerves and axons are unable to function properly, and the brain is unable to communicate with different regions of the body effectively. This subsequently leads to various MS symptoms. Symptoms of MS include muscle spasms, memory loss, vision changes, reduced cognitive function, reduced sensation, and loss of motor function. The symptoms of MS result in deficits in the motor pathway as well as cognitive function, thereby affecting the ability to process information, perform tasks, and draw on long-term memory. Hence, symptoms alter the individual's daily quality of life, including their mood, ability to do household chores, maintain employment, and participate in social events. The etiology of MS is believed to be multifactorial, where a combination of factors may contribute to the disorder, such as environmental factors, genetic predisposition, a virus, and recurring autoimmune disorder that targets the central nervous system, causing lesions in the white matter. There is currently no cure for MS, however, treatment is available to manage the progression of symptoms. Multiple sclerosis is classified into 4 categories, depending on its progression. Relapsing remitting MS is the most common type, affecting 85% of MS patients. It is when symptoms relapse or exacerbate upon long periods of remission, then show signs of improvement. Secondary progressive MS steadily progresses in late stages. Some patients with relapsing remitting MS may develop secondary progressive MS. Progression can be delayed with disease-modifying agents. Remission may or may not occur with symptoms subsiding at times. Primary progressive MS is when the symptoms worsen from the beginning upon diagnosis, with no remissions or relapses, with infrequent plateaus. It is more resistant to pharmacological intervention than the other types, affecting 10% of the MS population. Finally, progressive relapsing MS progresses from the start, with symptoms being exacerbated throughout the duration of the disease. This affects 5% of patients with no stages of remission.
It is estimated that more than 25,000 individuals live with multiple sclerosis in Australia, whilst over 2.5 million people are affected worldwide. It is most commonly diagnosed in young adults aged between 20 to 40 years, and women are 3 times as likely to be affected in comparison to men. Pain is prevalent with MS, with up to 75% of patients experiencing some form of pain, which could possibly be secondary to other symptoms such as fatigue, mood disorder, and spasticity. The primary cause of gait alterations in MS is CNS damage, which results in somatosensory loss. In particular, weakened motor control includes paresis, spasticity, and cerebellar ataxia, as well as sensation in the lower limbs. Common gait changes in multiple sclerosis include reduced gait velocity, decreased step and stride length, increased periods of double support, decreased swing phase, and increased step changeability. In patients with proprioceptive loss, muscular compensation of agonist and antagonist muscles in the lower limb occurs in an effort to maintain gait speed. In a study by Martin and others, results highlighted that people with early MS who present with mild neurological signs walk with reduced speed and stride length, limited ankle motion, and altered ankle muscle recruitment. The authors suggested in the early stages of the disease, motor function may start to deteriorate and affect balance, even when clinical signs of pyramidal dysfunction are not present. Somatosensory loss also affects muscle strength. Foot drop is a common condition in MS and is often the result of a paralysis and/or weakness in the dorsiflexor muscles. Lack of correct muscle activation creates compensatory mechanisms at the knee or the hip joints. Patients generally present with a steppage or hip hiking gait. Somatosensory involvement can cause proprioception loss. This results in gait limitations, with patients reporting instability due to sensory loss and an increased incidence of falls. MS causes muscle fatigue from morning and afternoon spasticity in the muscles. This affects postural foot control during gait, as well as the individual's upright standing position. Neurogenic pain is the most common and upsetting pain syndrome in MS. This pain is described by individuals as continual, penetrating, burning, or powerfully tingling, and is most often experienced in the legs and feet. Multiple sclerosis has similar symptoms to other diseases that affect the central nervous system, so its diagnosis can be difficult, and as yet there is no single test to diagnose MS. If MS is suspected, MRI can be used to support and substitute clinical information. Scanning of the brain and/or spinal cord will be ordered to check for areas of scarring and inflammation. The McDonald criteria of 2010 provides further criteria to aid in diagnosis. Criteria includes 1 to 2 attacks, evidence observable as T2 lesions on MRI, and positive evidence of elevated IgG and oligoclonal bands in cerebrospinal fluid. If MRI or other tests such as testing of cerebrospinal fluid are undertaken and are negative, extreme caution should be taken before making a diagnosis of MS. Differential diagnosis must be considered. If there is no better explanation for the clinical presentation and objective evidence is available, then a diagnosis of MS can be supported. Other examinations that may be undertaken include clinical assessment of coordination, motor skills, balance, sensory, language, and emotional function. An eye examination by an ophthalmologist may also be ordered, as well as electrophysiological tests to assess the conduction of nerve impulses. Performing a biomechanical assessment will help to analyse temporal distance parameters of the individual's gait pattern and to assess ankle joint range of motion. The purpose behind biomechanical assessments is to predict the functional evolution of MS without visible clinical gait disorders, and from there come up with a rehabilitation program to prevent an incorrect ankle-foot position that can result in a lack of motor control.
If a diagnosis of MS is made, there are a few ways in which we as podiatrists can be involved in the management of the affected client. Functional electrical stimulation, or FES, as seen in the left picture, is a device which applies an electrical current to a peripheral nerve to prompt muscle contractions which are involved with a functional activity. The devices are triggered by a switch in the heel or by tilt sensors on the leg. FES systems stimulate dorsiflexion of the ankle during the wearer's swing phase of gait. FES can immediately improve foot drop and walking performance in people with MS, acting like an orthotic. An ankle-foot orthotic, or AFO, as seen in the right picture, also works to correct foot drop during swing phase, allowing toe clearance. An AFO is a plastic device supporting the plantar foot and running behind the calf to passively dorsiflex the wearer's foot. AFOs are effective in correcting the ill effects of foot drop. However, many people stop using them as they can be uncomfortable, bulky, or just plain ugly. Another way in which a podiatrist can help a client manage MS is by falls prevention, education, and exercises to improve balance. This is a broad intervention incorporating strength and balance exercise, foot and ankle exercises, group exercise, interventions to maximize vision, podiatry interventions, interventions to modify medication use, and home modification programs. These have been shown to help reduce the incidence of falling. Pharmacological interventions are another way of managing the symptoms of MS. Zakowski et al. Recommend the use of dalfampridine, a potassium channel blocker, to increase walking speed in those with MS. Due to axon sheaths becoming demyelinated, potassium ions leak, resulting in the repolarization of the cell and reduced excitability. Dalfampridine acts to inhibit potassium channels, prolonging an action potential. Cameron and Wagner recommend the use of antispasticity medications such as baclofen, tizanidine, and benzodiazepines. Although effective in reducing spasticity, these drugs, if taken in high doses, can produce systemic side effects. Although we wouldn't be prescribing these medications to clients, it's still important that we are aware of the types of medications our clients with MS might be taking. Now for a quick review of the literature. In a Level 1 systematic review by Springer and Kalmus that evaluated the effects of FES on gait in people with multiple sclerosis, the authors found that FES had a positive orthotic effect on walking, but the therapeutic effects were not significant. Further, the dropout rates of patients in studies indicates that FES may not be suitable for all people with MS. In a systematic review completed by Wenning et al., it suggested that 14 out of 15 participants with MS did not benefit from the use of AFO during walking. There was no improvement with walking speed and various measurable modalities. In another study reported, there were progressive improvements when using FES device for 6 months. Conclusively, it can be noted that patients with walking deficits due to MS may benefit from either FES technology or AFO depending on the severity of the clinician's decision-making. Systematic reviews looking at exercise interventions were mixed. Amatia et al. Conclude that there is a low-level evidence that exercise therapy given with other interventions provides beneficial effects on spasticity specifically. Rietberg et al. Looked at 9 high-quality RCTs and concluded that exercise therapy can have benefits for people living with MS, particularly for muscle power function, exercise tolerance functions, and mobility-related activities. There was no evidence that exercise reduced fatigue or changed the person's perception of disability. An international symposium held in Oregon 2012 provided novel insights regarding the management and pharmacological interventions for MS. The medication dalfampridine, approved by the US FDA, demonstrated improvements with balance and walking speed for the affected individuals. However, further research is needed to examine other potential medications with similar benefits. Also, it was proposed that FES was able to improve gait and balance through the electrical current stimulation to the peripheral nerve and triggering muscle contractions during functional activity. Hence, this reduced the potential falls and provided better walking performance, which essentially mimicked the role of an orthotic for patients with MS. To summarize, multiple sclerosis is an inflammatory autoimmune disease. It causes demyelination of nerves within the central nervous system. This demyelination leads to impaired nerve function and the rise of MS symptoms. In the foot, these symptoms can present as proprioception loss, foot drop, and neurogenic pain. Currently, there is no cure for MS, with treatment aimed at managing symptoms and slowing disease progression. The podiatrist's role, thus, is to provide assistance to the individual with MS to help promote their quality of life and well-being. Next up, we have our scenario involving a client with MS.